Hello, and welcome to Survivorship Issues Following a Bone Marrow Stem Cell Transplant, including changes due to COVID-19. At this time, all participants are in a listen-only mode. If anyone should require operator assistance, please press *0 on your telephone keypad. A question and answer session will follow the formal presentation. You may ask a question anytime by typing it in to the Ask a Question feature on the left side of your screen. It's now my pleasure to turn the call over to your host, Jennifer Gillette. Please go ahead.
Thank you so much, Kevin, and thank you everyone for being here with us today. We're really excited to bring you this webinar on survivorship issues following a bone marrow stem cell transplant, including changes due to COVID-19. This is brought to you by a joint collaboration between MDMT Link and the Leukemia and Lymphoma Society. And just so, one second there. Just so everyone is aware of how our program is going to run today, first we're going to have Dr. Ed Perez, who's going to be discussing GVHD, chemobrain, advocating for yourself, and sleep issues. And then we're going to have Kristen Kinvogel, our nurse practitioner, who will be discussing stress, fatigue, and nutrition. And then we have Ailey Armstrong, a social worker, who will be discussing anxiety, depression, mood disorders, mindfulness, and PTSD. And then we have Marilyn Woods, who is an AML survivor and will be bringing the patient experience to you. And then, of course, we will have our questions and answers after the presentation. For those who might not be familiar with NBMT Link, we are dedicated to helping individuals and their families from diagnosis through survivorship. We work with hospitals, cancer centers, and other organizations to reinforce and complement medical care by providing resources and education. If anyone wants any additional information, we have our phone number there as well as our email contacts. And at the end of this call, there's going to be a survey. If you hold on before logging out, not only can you answer that survey and help us know how to best serve you, but also contact information is in there as well. Some of the resources that the National Bone Marrow Transplant Link provides is, first of all, we have our Lunch and Learn programs, podcasts, multiple webinars like the ones you are on today, blogs from those who have been through the transplant process on all things related to transplant, including we have information about disease-specific information, survivorship issues, coping, and symptom management. We have an excellent peer support mentor program for patients and caregivers, our second birthdays recognition program. We have several books and resources to provide for people. We also provide emotional support from a licensed social worker. And we have great social media outreach as well, providing tips and stories and connections to things going on that can be of help to you. A special thanks to our webinar event sponsor, the Leukemia and Lymphoma Society, as well as our Team Link partners. They make these programs possible. And there is a list of all the wonderful people that help us. And just a medical disclosure for today, the information provided today is to stimulate conversation between you and your healthcare provider, but keep in mind you have an individual medical plan with your provider, so it promotes discussion. We're not giving individual medical advice. Now, to hear more about our speakers, as I had mentioned, we're going to have Dr. Ed Perez with us here today. He's an associate professor with Wayne State University, hematology oncology, stem cell transplant, cellular therapy, and is at the Henry Ford Cancer Institute. He went to medical school at Ross University. He did a residency at the Children's Hospital of Michigan, Wayne State University. He did his fellowship in hematology oncology at Children's Hospital of Michigan, Wayne State University. And then he is currently at Karmanos Cancer Institute, he did his fellowship at Karmanos Cancer Institute, but is currently at Henry Ford. And then we have Kristen Kinvogel, our nurse practitioner here today. She is an advanced registered nurse practitioner at Seattle Cancer Care Alliance, Fred Hutch University Washington Medical Center in Seattle, Washington. She received her Bachelor of Science in Biology and Environmental Studies from Bowdoin College in Brunswick, Maine in 2003. She completed her Master of Science in Nursing with a Family Nurse Practitioner certification from Massachusetts General Institute of Health Professions in Boston, Massachusetts in 2008. She has worked as a nurse practitioner at the Seattle Cancer Care Alliance since 2009. She initially worked in the acute bone marrow transplant group since 2015, and she worked in the long-term follow-up group. The long-term follow-up group provides post-transplant consultation services to stem cell transplant recipients beyond day 80 post-transplant. She enjoys being part of a multidisciplinary team that she can provide holistic care to stem cell transplant recipient survivors. Kristen is a founding member of the International Society for Cellular Therapy Advanced Practice Provider Committee. And then we have Ailey Armstrong. She is a licensed clinical oncology social worker and member of the Integrated Psychosocial Oncology Program at the Seattle Cancer Care Alliance, where she provides psychosocial support and care coordination to patients on the bone marrow stem cell transplant service and their families. Using a variety of evidence-based therapeutic modalities, including behavioral activation and problem-solving treatment, Ailey works closely with patients over the course of the transplant process to help them cope with the emotional and physical challenges that accompany treatment. Ailey also co-facilitates the SCCA's Young Adult Support Group and is a member of the SCCA's Vital Talks faculty, providing training to SCCA staff on the communication skills for discussions around serious illness. She received her master's degree in social work at the University of Washington, where she was a Carol Lemaire Scholar in Oncology and Palliative Care. And then we have Marilyn Woods. She is an AML survivor. Marilyn has made some wonderful slides introducing herself, so I will just say for now that she's a Michigander that's been married for 49 years, and she is a woman on the move that loves life, loves family, and has a great deal of wisdom on what can be helpful during the cancer journey, and will share her best tips for coping with life after treatment. And so now, Dr. Perez, thank you for being with us today, Doctor.
Good afternoon, everyone. This is Edward Perez. I am the Associate Professor for Hematology Oncology, Stem Cell Transplant, and Cellular Therapy at Henry Ford Cancer Institute at Wayne State University. And I will be speaking in regards to the challenges during COVID-19 for patients who have undergone stem cell transplant. So an overview of this discussion will be in regards to the management of acute and chronic GVHD, cognitive impairment, including sleep issues after stem cell transplant, and really kind of an unfortunate situation currently is navigating care during the pandemic due to COVID-19. So the background of acute graft versus host disease is that it occurs in up to 25 to 30% of patients undergoing a related allogenic transplant and up to 45 to 50% of unrelated donor stem cell transplant. The incidence of grades 2 to 4 GVHD is even higher if you undergo a mismatched transplant, and for alternative donor transplants in regards to cord blood or haplo is variable in regards to the range of 16 to 30%, depending on if it's a single or double cord. The target organs that acute GVHD involves include the skin, GI tract or intestine, as well as the liver. The skin can be involved in a very low grade, and we really kind of track that based on the body surface area that's involved. This is due to the HLA disparity, so even though you've undergone a stem cell transplant with a perfect 10 out of 10 or now 12 out of 12 donor, there are still quite a few HLA disparities that are found in patients who are undergoing those transplants. And again, that does cause those rates of GVHD. Graft versus host disease is an important cause of early mortality post-transplant and has a major impact on quality of life and long-term immune suppression because we know the incidence of chronic GVHD once one has developed acute GVHD can be significant. So the signs of acute GVHD can be the development of a very faint pruritic rash or even a severe sunburn-like rash with blisters. And again, it can be it varies. It can involve just the facial area, the lower area, so many different variants. And it is important you bring those to your caregiver's attention. In regards to the GI tract or intestines, post-transplant, you're on a slew of medications, and again, nausea is a pretty common complaint once a patient undergoes a stem cell transplant. So after that 30 to 100 days point with those medications, even taking antiemetics, it's really nausea that doesn't go away. It continues all day, loss of appetite. It's important in regards to monitoring weight post-transplant. You can lose up to 10% of your weight going through a transplant, but again, if that weight continues to be low after transplant, that is a concern. Emesis or vomiting. So again, the majority of patients can have upset stomach and throw up due to the medication load that we require. However, if it's persistent throughout the day, 2 to 3 times, again, that would be concerning for upper intestinal GVHD. And then feeling full after eating very little, again, is a common complaint once patients are discharged to home. Caregivers are very concerned in the amounts patients eat once they're home and eating very small amounts. Again, if that continues even after the discharge and is persistent with weight loss, that is a concern for upper intestinal GVHD. For lower tract disease, that is pretty common complaint is loose stools, belly pain that doesn't go away, feeling bloated, and then obviously blood in the stool is a major concern in patients who have post-transplant. Liver GVHD can present, usually it's concomitant with skin or GI tract GVHD, but again, it can present alone. Skin and the eyes can look yellow. You can have right upper quadrant pain in dark or tea-colored urine. The gold standard for management of acute GVHD is corticosteroids, along with local treatments depending on which organ's involved. Skin, you can use steroidal or emollient creams, and that will be managed by your physician in regards to the potency of those agents. The GI tract, we can use oral agents that include oral steroids with concomitant corticosteroids. And then the mouth and or the oral mucosa in regards to steroid rinses and ocular dryness management with different agents, including artificial tears. We have actually in our clinic, we give a nice handout in regards to all of the different modalities of treatments for all of the organs that can be involved, and we send those home with all of our patients. The response to treatment is really the most important factor to determine the tapering of immune suppression and steroids. So the side effects of steroids when patients are on, in increased amounts of corticosteroids or, weight gain, emotional changes, bone health is impeded. So again, that's an important modality is to try to taper down the immune suppression based on response, and different centers do that differently over a 5-day to 14-day reduction. And the risk of development of GVHD is really based on, 2 different factors, the donor HLA disparity and then the conditioning. The intensity of conditioning does have some influence on it. Many of your managing clinicians will consider other therapies, including Jakafi or a JAK-STAT inhibitor, mycophenolate mofetil, extracorporeal photopheresis, and even clinical trials in the management of acute graft versus host disease. And the goal in regards to the management of graft versus host disease is to taper down the immune suppression, build tolerance, and prevent relapses of graft versus host disease recurrence. The majority of clinicians and patients get a little frustrated in regards to recurrences or the time frame to get off the treatment, and that is one of the major complaints we get in regards to trying to taper down the steroids very quickly. But again, we have to be cognizant of the fact of building tolerance and getting the patients off steroids in a very limited time frame is sometimes concerning because, again, recurrences, you have to go up on treatment and for a prolonged period of time. Tolerance will develop, and again, it will get better. It just takes time, and you have to be patient in regards to the response. The other concern is in regards to overlap syndrome, which may manifest with features of both acute and chronic GVHD, and the management of that is, again, will be discussed soon. So moving on to chronic GVHD, and I talked a little bit about the overlap syndrome, which I'll discuss here. Once you've gone through acute GVHD, if you've had, low grade, grade 1 or 2, or minimal body surface area, which you've been able to just treat with topical therapy without systemic therapy, or low grade gastrointestinal GVHD, which improve without systemic steroids. However, again, subsequent episodes with recurrence or persistence or new onset or late disease can be persistent. And then as the treatment and the tolerance builds, one can develop chronic GVHD, which can involve every organ, most commonly oral and ocular GVHD, again, which we treat mostly with local treatment. However, the most concerning factors in regards to the lung and musculoskeletal need to be managed and monitored very closely. When we have both chronic and acute GVHD or the overlap syndrome, that can be treated with, again, the gold standard is corticosteroids with some adjuvant therapies, including local and systemic treatments. So if one looks at a timeline in regards to the development of acute GVHD, for those who have undergone a fully myeloablative transplant, again, it is pretty common to see that day 100 involvement and then chronic thereafter. However, with the advent of reduced intensity or non-myeloablative, some of these symptomatology can proceed into the time frame over 100 days, and the development of what this classic overlap syndrome can develop, where you develop acute and chronic at the same time. If one looks in regards to the lesions, in regards to the inflammatory cascade and tolerance that occurs, and corticosteroids can be very helpful to prevent progression and repair the organ involved without undergoing that fibrotic damage. The management of chronic GVHD is very complex, and it really entails a multidisciplinary approach in regards to eye or ocular involvement. The ophthalmologists really need to be involved in regards to treating dry eye, using the artificial tears and local treatment with steroid drops or Restasis. Skin, again, really needs to be managed to prevent the development of fibrosis. The two areas in regards to the non-fibrotic skin management and fibrotic skin management really need to be addressed. Those include topical steroids, steroid shampoos, emollients, protopic therapy in regards to creams. And then in conjunction with that, yoga, stretching, massage, therapy, physical exercise are very important in regards to maintaining the overall skin health, as well as the stamina. In regards to patients being on steroids, we know that can cause myopathy or muscle weakness, and we want to prevent significant deterioration or the development of deconditioning, where you develop muscle atrophy. That is very important in regards to the management of these patients. Oral GVHD with topical steroids, is an important modality, and weight loss has to be really looked at in regards to nutrition and oral health, and we use combined treatment with the dental professionals to really manage this. And then pain management, again, is very important in regards to the fibrotic skin disease causing pain and stiffness. And again, that is a multidisciplinary approach we use with our pain management team as well. Moving on to the cognitive changes after stem cell transplant. So with all the stressors now, including the pandemic and going through the different modalities of chemotherapy and then transplant, there's many different experiences patients go through during and after chemotherapy, including difficulty with new learning, taking longer periods of time to complete tasks, troubles multitasking, and difficulty finding the right words, even during clinic visits. And the caregivers seem to do a lot of the talking for patients who have difficulty with the cognitive changes after stem cell transplant. That's why it is important that you bring those to the attention of your healthcare provider, because there are definitely many different modalities that we can utilize in managing this. So cognitive therapists can really help in regards to an overall plan for management. I think the frustration is really bringing this to the attention of the care provider and addressing it. Sometimes early after the transplant, we wait and see what in regards to the overall cognitive impairment and if it improves versus addressing it kind of head on. The other factors that one has to take into consideration in regards to worsening cognitive impairment can really be sleep deprivation. So sleep management is very important. Patients who are early out of transplant, they tend to sit in the chair or bed, they're not moving, they sleep during the day, and then they're up all night. So again, sleep management is really, really important. We recommend that the majority of our patients' population try to stay awake during the day and then, rest at night. And stress management, and again, in regards to the pandemic, this has become more stressful for patients if it wasn't stressful enough. Exercise and activity can really help with cognitive impairment, especially yoga and mindfulness classes. And again, addressing the depression, that is really something that we try to do, and again, a multidisciplinary approach with our psychologists and social workers. With cell phones and the ability to do apps, there are many different approaches in regards to games, cognitive behavioral therapists that you can download. There's a Mind Doc, there's calendars with reminders, alarms that can all be very helpful using your cell phone as kind of your second brain or reminder in regards to some of those modalities. I actually went on the apps and found many different downloadable therapeutic options in regards to the behavioral health and therapy on the apps. And again, with the pandemic, that is actually a reasonable option for patients who don't want to actually be seen in a clinic in a live visit. So the caregiver and patient really need to address the transplant issues as they go through both acute and chronic GVHD, cognitive impairments, depression, sleep management, physical activity, nutrition. Again, it really takes a multidisciplinary approach, and I think the caregivers really need to advocate because they're the ones that are spending the most time with the patient that's gone through this therapy. And then moving to care during COVID, as everybody knows, it's been a challenge. The care of patients during transplant admissions has been significantly impacted by COVID-19. trying to maintain COVID-free space in the clinic as well as units is really impacting the workforce and care. Visitor restrictions, so again, that caregiver that has spent the majority of time with the patient now is, during a period of time where they were not allowed to be with their patient, their family members and friends. And this has led to additional stressors for those undergoing transplant or post-transplant, including isolation, increased anxiety, and it's really difficult in regards to the communication with family members and discussions about the status of a patient who's undergone a transplant with complications post-transplant, including acute GVHD, chronic GVHD, and infectious complications. Since the majority of our patients who have undergone treatment will develop fever and cough, obviously that increases the anxiety and stress of being diagnosed with COVID. And this is something that really is very difficult, and it's a challenge because when we were unable to get turnaround tests very quickly and calls from patients of where to go and where to get tested, again, led to many different challenges that we've tried to address working through this. Follow-up after a transplant is really essential, and we have to monitor, the blood counts, fatigue, weight gain and weight loss, and then diet and activity of our patients who have undergone this treatment, trying to minimize visits during this pandemic, and the incorporation of telemedicine has become the standard now to prevent exposure to COVID. However, this has really led to, the caregivers and the patient having to do additional care and monitoring at home, trying to avoid the ER post-transplant. The additional costs, if you can even get a pulse ox from Amazon, if that takes 2 to 3 weeks nowadays, blood pressure cuffs, scale, other items. And again, it really adds additional stress and anxiety for the patient and the caregivers who must perform this prior to their telemedicine visits. I've actually trained all my patients to do blood pressures, pulse ox, and weights prior to their visits. It's worked out extremely well, but again, it is additional work that usually the nurses would have provided. The additional measures in regards to hand hygiene, social distancing, avoiding travel, and private transportation has really been deemed essential. I mean, if it wasn't bad enough without the pandemic and this social isolation, now it's even gotten prolonged. The physical and social isolation, well, usual practice for patients going through this therapy is now really extended for a prolonged period of time. So just when you thought you were going to get a break and be able to do some things, now you're kind of stuck at home, quarantine as well. Local nursing services has extended further for a follow-up period, again, because of the inability to visit cancer centers. And additional triage and tests prior to essential visits are mandatory, which leads to additional strain on the cancer center and staffing. And I think for the majority of patients are really concerned that when they come into our center, trying to get their visits quickly in and quickly out into private rooms. However, they're still kind of going through the hospital prior to being seen. So managing the multitude of post-transplant fatigue, stress, depression, and physical activity, trying to incorporate coping skills to address fatigue and loss of physical activity with the online resources that include yoga, strength training, and mindfulness are really important because, again, the ability to get out to physical therapy or have physical therapists or occupational therapists in the home has really been stretched thin due to the COVID pandemic. And really the inactivity has led to additional stressors and muscle wasting, depression, and additional fatigue. So I think it is important that you spend time doing some physical activity, trying to prevent that fatigue, trying to work on the anxiety and the stresses that everybody is going through this pandemic. And it's really been very difficult for our patient populations since they're already stressed out to begin with. So telemedicine has been essential. However, recognition of acute and chronic GVHD can be challenging. The phone system, the internet, has really caused the majority of healthcare providers to really rely on those modalities to see patients The other issues in regards to photophoresis, the management of steroids and immune suppressants, increase of the ability to really respond to COVID infections. So again, we try to minimize the visits and avoid exposure and minimize the risk of infecting our patient population. The management of fever from different entities, including viruses, bacteria, avoiding the air is again complex, and the need to rule out COVID prior to admission remains challenging if somebody does have to be admitted for further management. We try to obtain those tests and do everything we can prior to the patient coming in so we avoid, again, additional exposure. So in summary, the COVID pandemic has really resulted in unprecedented challenges to transplant programs and patients. In Michigan alone, over the weekend, we had 2,900 cases. This past weekend, transplant centers have really transitioned to telemedicine and outpatient labs, avoiding the need for unwanted exposure, maximizing support for each transplant center, and utilizing the internet for mindfulness and activity is helpful in these unprecedented times, with the hope to returning to some degree of normalcy in the near future. And I think that's the end of my talk.
Thank you, Dr. Perez. And now we'll have Kristen.
Okay. So I'm Kristen Kinsvogel, a nurse practitioner in the long-term follow-up group at Seattle Cancer Care Alliance Fred Hutch Cancer Research Center in Seattle, Washington. I'm delighted to be here today to discuss survivorship issues after stem cell transplant during the COVID-19 pandemic. I have no conflict of interest to disclose. So I want to tell you a little bit about the LTFU program at SCCCA, how we modified our practices during the COVID-19 pandemic, and then a couple of survivorship issues that I frequently encounter in my practice, fatigue and nutrition. The long-term follow-up group offers lifelong consultation to approximately 6,000 post-transplant patients and their primary providers, and this is for patients who are day plus 80 and beyond after transplant. We practice in a collaborative management model between us, the patient, and the primary provider. We conduct research and provide clinical services. This collaborative management model involves obtaining information and questions from the patient and or primary provider, and in turn providing recommendations to the patient and or provider regarding chronic GVHD management or other post-transplant complications. The major type of consultation services that we provide include a pre-discharge home clinic for those who are around day plus 80 post-transplant to evaluate for chronic GVHD and to educate the patient about chronic GVHD and post-transplant complications. Chronic GVHD evaluations, a comprehensive week-long, one-year post-transplant evaluation that includes disease restaging, as well as telemedicine consultation, which entails communication between nurses and attending physicians and the referring provider and their patient. And this telemedicine is mainly phone and email that does not include video. The effect of COVID-19 on these practices definitely modified how we operated. The first U.S. case of COVID-19 was identified in Washington State on January 1st of this year, and it clearly led to the rapid increase of cases necessitating modification of our LTFU practice. In March, the majority of our clinics were switched to telehealth, which included video assessment, and the comprehensive annual evaluations were deferred. We still offered in-person GVHD clinic evaluations for those that were concerned for progression of GVHD that had physical exam findings or concerns that were not amenable to evaluation via video, such as sclerosis or other skin findings. Our center implemented universal masking, symptom screening via email well in advance of the patient's appointment, and via phone, as well as symptom screen on the day of the appointment. Patients were only allowed to have one caregiver accompany them to the clinic. And I have to say the time spent reviewing charts, discussing symptoms with patients, and choosing whether or not they should be seen in the clinic or change to telehealth was absolutely extraordinary. The nurses fielded tons and tons of inquiries from patients, so it was all very time-consuming. But fortunately, by June, when the cases improved, we reverted our clinics mainly back to in-person, but we have still offered telehealth, as it's been very beneficial for patients who require extensive travel, like flights or long drives, or those who have significant comorbidities or just are very concerned about exposure to COVID-19. We've enabled them to still be evaluated in a timely fashion by LCFU. So on to survivorship. Long-term survival is an expected outcome after stem cell transplant, but the burden of morbidities is significant. Stem cell transplant survivors, when compared with their siblings, are twice as likely to develop a chronic condition and 3.5 times as likely to develop a severe or life-threatening chronic condition. Those with chronic GVHD were 4.7 times more likely to develop a severe or life-threatening chronic health condition. The cumulative incidence of chronic health conditions among stem cell transplant survivors was 59% at 10 years after transplant and 35% for severe or life-threatening chronic conditions or death at the 10-year mark. What are these chronic health conditions? Well, they can certainly be widespread and affect nearly every part of your body. You can have neuropsychologic effects, including depression, anxiety, pulmonary dysfunction, renal diseases, osteoporosis, osteopenia, endocrine dysfunction, subsequent cancers, potentially affecting your oral cavity, esophagus, breast, prostate, cardiovascular diseases, heart attacks, strokes, arrhythmias, infection, and many of these chronic health conditions can contribute to fatigue. Fatigue is one of the most commonly reported problems in our annual survivorship survey that is completed by stem cell transplant recipients from SCCA and the Hutch. And clinically significant fatigue has been found to remain significantly elevated among long-term transplant survivors compared to the general population. And while it is a very common complaint in my clinic, it is still quite challenging to treat. Cancer-related fatigue is defined as a distressing, persistent, subjective sense of physical, emotional, and/or cognitive tiredness or exhaustion related to cancer or cancer treatment that is not proportional to recent activity and interferes with usual functioning. It's usually graded on a scale of 0 to 10, indicating mild, moderate, or severe. The etiology of it is not entirely understood, but it is likely multifactorial. There are certainly treatable comorbidities that could be contributing or causing fatigue, such as endocrine dysfunction, hypothyroidism, adrenal insufficiency, hypogonadism, infection, pulmonary dysfunction, cardiac dysfunction, anemia, arthritis, alcohol or other substance use, emotional distress, depression, anxiety, financial stress, medications such as narcotics, antiemetics, sleep aids, the presence of pain, sleep disturbance, including insomnia, apnea, restless leg syndrome, nutrition, weight and caloric intake changes, fluid electrolyte imbalances, deconditioning with loss of muscle mass, decreased stamina, chronic GVHD, and there is certainly growing evidence that inflammation may contribute to fatigue, which is oftentimes increased from several factors from above. Fred Hutch conducted a study measuring fatigue severity based on patient responses from the annual survivorship survey. The FSI, or fatigue symptom inventory, was used to measure fatigue severity during the preceding week. The FSI is a 14-item scale that assesses the frequency, severity, and disruptiveness of fatigue, and scores greater than or equal to 4 are consistent with moderate to severe fatigue. The study found that 31% of subjects met criteria for moderate to severe fatigue. I think my slide got, okay. And that for allogenic transplant recipients, female sex, presence of chronic pain, and current severity of chronic GVHD were independently associated with greater fatigue. For autologous transplant patients, younger age and current presence of chronic pain were found to be independently associated with greater fatigue. Depression and fatigue were significantly correlated. And furthermore, each increase in chronic GVHD severity, such as from mild to moderate or moderate to severe, was associated with a 77% increase in the likelihood of moderate to severe fatigue. The presence of chronic pain was associated with increases of greater than 400% in the likelihood of moderate to severe depression and fatigue in allogenic stem cell transplant survivors, and greater than 200% likelihood of moderate to severe depression and fatigue in autologous stem cell transplant survivors. These results suggest that patients who report chronic GVHD or chronic pain are at particular risk for fatigue and depression. Of note, this study did not find a significant relationship between time from transplant, type of conditioning, or complications during transplant that would affect fatigue. Another study from the Hutch revealed strong evidence to suggest that chronic GVHD significantly affects quality of life and fatigue. The study evaluated patient-reported outcomes from the annual survivorship study at the Hutch. Patients completed the Promise 29, which is a 29-question survey with 7 subscales, 2 of which are physical function, which is ability to perform household chores, walk up and down stairs, go for a 15-minute walk, do errands, and social, which is one's ability to participate in social roles or activities, such as spending time with friends, working, etc. Higher scores indicate better functioning, and on the graph, N equals never had chronic GVHD, R equals resolved chronic GVHD, and then there's mild, moderate, and severe chronic GVHD. The general population mean is 50, and what they found was that patients who reported moderate or severe chronic GVHD reported worse quality of life, lower performance status, higher symptom burden, and were more likely to be taking prescription medications for pain, anxiety, and depression compared to those with resolved chronic GVHD. Between 25 to 40% of people with active chronic GVHD were unable to work due to health reasons, compared to 12% whose chronic GVHD had resolved and 15% who never had chronic GVHD. In terms of treatment, it's first and foremost very important for the provider to screen for fatigue and distress often. Treatment of fatigue likely requires a multidisciplinary approach. Of course, treating and preventing underlying health conditions is crucial, but oftentimes this is easier said than done. Of course, working up endocrine issues and treating chronic GVHD, but that can be challenging in itself. And then energy conservation. Set priorities, pace yourself, schedule activities at times with peak energy, and gradually build up your activity. Physical activity. This is one aspect that has been shown to improve fatigue, and the goal is to participate in at least 150 minutes of moderate activity over the course of a week, and then engage in 2 to 3 sessions of strength or resistance training per week, as well as stretch 2 days per week. Oftentimes, a physical therapist or occupational therapist may help to establish an exercise program, especially if you're quite deconditioned. Cognitive behavioral therapy, including that for sleep, as well as mindfulness-based stress reduction, supportive expressive therapies, and acupuncture. Nutrition consultation, and finally psychostimulants such as Ritalin, which are less used but can be considered if other modalities are not effective. And especially during the COVID-19 pandemic, if you're experiencing fatigue, it is worthwhile to continue to seek and initiate workup for this, as it can take considerable time. Okay, on to nutrition. So nutrition and diet are certainly less addressed by the patient, but often incorporated by the provider as part of a treatment plan for other chronic problems. Nutrition can be affected by chronic GVHD, oral, esophageal, gastrointestinal, medications, dental health, comorbidities, stress, and financial resources. One should optimize their nutrition to benefit cardiac health and metabolic syndrome, dyslipidemia, hypertension, diabetes, bone health, including osteopenia, osteoporosis, infection risk, and recovery from transplant. We know from a study at our center that even after discontinuation of immunosuppression, that long-term survivors of allogeneic transplant appear to be at increased risk relative to their siblings for developing diabetes and hypertension. But we also know that from a study from our center that therapeutic lifestyle changes, including diet, exercise, and modified behavior, can mitigate this increased risk of cardiovascular effects in post-stem cell transplant survivors. So we need to consume a heart-healthy diet, which entails consuming no more than 7% of saturated fat of your total calories. Cholesterol should be less than 200 to 300 milligrams per day, and red meat consumption should be no more than 12 to 18 ounces per week. Consume a diet rich in omega-3 fatty acids. Some of these sources could be flaxseed oil, walnut oil, soybean, salmon, herring, mackerel. If these sound unappealing, you're not in the minority, but you can try to supplement. However, the precise amount of omega-3s in over-the-counter supplements is not regulated. Maintain a normal weight. BMI for normal weight is 18.5 to 24.9. And then consume plant-based foods. 2/3 of your plate should contain plant-based foods, such as vegetables, fruits, beans, lentils, whole grains. And then, of course, limit processed, high-fat, high-sugar foods, such as soda and candy. Hypogonadism, prednisone therapy, conditioning regimen, and generalized deconditioning can increase stem cell transplant survivors' risk of osteopenia and osteoporosis. In terms of diet, it is very important to optimize calcium and vitamin D. Ideally, you can fulfill your calcium requirement with diet, but if necessary, you can certainly take a supplement. Either calcium citrate or calcium carbonate are preferred. Calcium citrate can be absorbed. It does not require a high acid environment to be absorbed, so it's preferred if you're taking a proton pump inhibitor. Calcium carbonate usually comes with vitamin D and requires to be taken with meals. And then the amount of calcium requirement varies based on sex, hormone replacement therapy, and whether or not you're on prednisone. Vitamin D 25-hydroxy level goal is 30 to 50, and hopefully can be maintained with a daily vitamin D dose. If the level is 20 to 30, then the dose can likely be doubled. If you're deficient with it less than 20, then high-dose ergocalciferol on a weekly basis for 8 weeks is recommended. And then if you're on prednisone, sodium can increase urine calcium loss. So if you can limit your sodium in your diet while taking prednisone, it may help preserve bones. The goal of food safety is to minimize the introduction of pathogens into the gastrointestinal tract. Contraindicated foods are high risk and known to be potential sources of organisms that can cause infection in immunosuppressed patients. This list is certainly not comprehensive, and if you go to the link at the bottom of the slide and click under resources, you can find a detailed, comprehensive list. We recommend an immunosuppressed diet and safety guidelines to be followed as long as you're on immunosuppression, or for autologous stem cell transplant recipients, it should be followed for 3 months post-transplant. Damaged tissues, especially associated with chronic GVHD or transplant conditioning regimen, may benefit from increased protein in your diet to aid recovery. And sources of protein should be lean meat, dairy, soy, and nuts. And then if you've lost weight or lost significant muscle mass, increasing protein in your diet and considering small, frequent, nutrient-dense meals, such as those supplemented with like avocados or nut butters, may be beneficial. In summary, stem cell transplant recipients have increased relative risk of chronic health problems after transplant compared to their siblings. Fatigue is multifactorial in nature and likely requires a multidisciplinary approach for treatment. Providers should screen for fatigue often, and treatment of one symptom or problem may improve another. There's clearly a need for additional research looking at or evaluating the treatment and prevention of chronic GVHD given its significant relationship with fatigue and quality of life. Optimizing nutrition may attenuate the increased risk of chronic conditions in the post-transplant setting, especially in combination with other therapeutic lifestyle changes such as exercise. COVID-19 pandemic creates new challenges but has provided opportunity to reevaluate system processes and hopefully improve upon them. For us, telehealth has been very well received by the patients and has enabled us to evaluate patients in a timely manner. And finally, stem cell transplant recipients are resilient. They're survivors, and they should advocate for themselves, especially during the pandemic. They need to be proactive and get their concerns addressed. Quality of life matters. Thank you.
Thank you so much, Kristen. That was a fabulous presentation. And now Ailey Armstrong will join us, our social worker from the Seattle Cancer Care Alliance.
Yes, hello. Again, my name is Ailey Armstrong. I'm a clinical oncology social worker at Seattle Cancer Care Alliance. I've worked there about 7.5 years, and in the last 4.5 years, I have worked specifically with people who've undergone either autologous or allogeneic stem cell transplant. So today I'm going to be taking a very fast and quick look at how to address emotional challenges in post-transplant survivorship, that there are these challenges, and some thoughts on how to cope with them. So just to get started, and I know I'm probably preaching to the choir on everybody that's on this call, but we know that even though transplant is a medical procedure for a health condition, it affects almost every aspect of one's life, including the physical, the psychological, and social and spiritual realms of well-being. And some of these effects have been discussed by Dr. Perez and Kristen can be quite negative and quite challenging. Certainly there are the ongoing and chronic physical symptoms. There are severe financial stressors, work-related concerns, ongoing concerns about body image, return to sexual function, and so on. However, some of these effects can in fact be positive. Some people experience an increased appreciation for life and relationships, strengthened faith, recalibration of priorities to focus more on what they truly value. So our focus today is really going to be on that orange box, psychological well-being as an effect of transplant. But we know that psychological well-being is affected by physical well-being, social well-being, spiritual well-being, that all of these realms are deeply intertwined and connected. So post-transplant distress is definitely common. We know that this comes up, and gosh, it's only gotten more common in this pandemic era, I'm sure. One study from 2007 showed that about 43% of long-term stem cell transplant survivors, so these survivors were on average about 3.5 years out from transplant, 43% reported clinically significant global psychological distress, and 1 in 4 identified as having clinically significant symptoms of anxiety and depression. These survivors also reported persistent concerns with cognitive impairment. That's something that was discussed by Dr. Perez, as well as feelings of loneliness while in the presence of others. So being around other people, these survivors felt disconnected, not understood, and isolated even when they were with other folks. The authors of this study also had another study that showed that about 5 to 13% of stem cell transplant survivors have experienced post-traumatic stress disorder. So I think the message of this slide is really, if you have experienced any mood changes in the aftermath of transplant, you are certainly not alone. This is very, very common. So let's take a quick look specifically at anxiety, depression, and post-traumatic stress disorder. So some of the symptoms associated with each of these are pretty obvious. They really point to specific mood concerns. For anxiety, excessive worry that is difficult to control. for depression, feeling down, depressed, or hopeless, for post-traumatic stress disorder, experiencing flashbacks, nightmares, hypervigilance. All of these are things that we would associate with these specific disorders. Some of the side effects or symptoms might be less obvious or could be attributed to other factors. For example, fatigue, as Kristen mentioned, difficulty concentrating, sleep issues. All of these are associated with these disorders, but they may also be caused by medication and treatment side effects. We know that high-dose chemotherapy can cause concentration issues and cognitive changes for a period of time. Steroids can certainly cause irritability and restlessness, as well as disrupt sleep. Certainly, mood issues can be associated with stress that accompanies the transplant experience, financial, relationship issues, all of those things. And regardless of the cause, just to backtrack a little bit, prior history of trauma can certainly compound one's experience in terms of coping post-transplant. So regardless of the cause, whether you're having medication side effects, whether things are being caused by stress, as both Dr. Perez and Kristen have pointed out, it's really important to consult with your medical team, talk with your doctor about the symptoms that you're experiencing, and work with your team to get a plan for support, because this is not, these are not experiences that you need to suffer with, that you have to just put up with. There are things that can be done. So, time points for distress after transplant. We know that distress can arise at any point after transplant, but there are some specific periods where it is a little bit more common, certainly in the acute post-transplant period, 30 to 100 days after transplant, but also when you discharge from your transplant service and perhaps return to your primary oncologist. Most people expect that this will be a time of elation and are really surprised by the fact that they might actually experience this huge emotional wallop of low mood, of anxiety, other things when they get back home. Management of chronic or late side effects, particularly if those side effects are really debilitating. And then returning to work or determining that you can't really return to work for a period of time. That can be an incredibly emotional and stressful period. And certainly one period that we could not have anticipated as a period for post-transplant distress is this global pandemic. I think both Kristen and Dr. Perez have talked very specifically about things that they've seen among patients who are struggling with the added layer of stress, of fear, of uncertainty. You know, people who are immunocompromised both pre and post-transplant have very reasonable reasons to be afraid of contracting COVID and wanting to protect themselves, and wanting to make sure that they're not exposed. You know, there's certainly grief over the many losses that people have experienced. You may know somebody who's gotten sick with COVID or who has died as a result of COVID. You may have had to miss out on things that you were looking forward to post-transplant, weddings, baby showers, family reunions, things that you had hoped that you might finally be able to attend. There's greater isolation in general from family and friends, increased financial and job-related stress. Many people have lost jobs or been furloughed. Caregivers are shouldering even more demands now, particularly if you have a family with children who aren't able to attend school currently. And all of us are coping with a heightened sense of uncertainty about the future. And some of us may even be kind of fed up and ready to be done with this pandemic. And that may mean that some of the folks around us aren't taking as many precautions, and that can lead to a lot of stress among friends and family as well. Of course, anecdotally, some of the transplant survivors I've spoken with have said that they feel like they're actually better able to cope with the pandemic because of their experience living under the constraints of needing to be cautious post-transplant. They actually feel like they've already adapted to the situation that everyone else is having to live with right now. So addressing distress, what can you do? Well, first and foremost, seek support, professional support, peer support, and support among your current social networks. In terms of professional . companion on your journey through this can be so valuable. Seeking peer support, so many of the national transplant organizations, including NBMT Link, offer peer support options. There's nothing like talking with somebody who has been through a transplant, and getting their advice and their understanding can be invaluable. And then maintaining connection with your own social support networks. And I know everybody is sick to death of Zoom right now, but as we enter this dark winter season, it's more important than ever that we be intentional about remaining connected with our social networks, family, friends, church members, colleagues. Those connections are vital to our mental health. I know that Dr. Perez and Kristen mentioned exercise, remaining engaged in physical therapy if that's something that you do. And while we know that COVID precautions and living with transplant-related comorbidities can make getting out for our usual forms of exercise hard, there are ways to be creative, watching YouTube videos online for yoga and other exercises, going for a short walk in a non-populated area, all bundled up for winter. So just being really intentional and thoughtful, again, about engaging in these things. For many people, finding ways to give back or pay it forward after transplant is hugely life-affirming. And so many people just say that they feel so much better when they can contribute to someone else after they go through this process. And then consider a medication evaluation. We know that medication can't solve everything, but many people find psychotropic medication helpful to boost mood, increase energy, lessen anxiety, and improve sleep. And it can also be helpful to talk with your doctor about your current medications to see if there's anything that might be modified to lessen possible mood or sleep-related side effects. So one specific thing that I'd like to take a few minutes to talk about, because it's such a powerful tool for recovery, is mindfulness. So our minds naturally are focused on things that have either happened in the past or that might happen in the future. And we are wired this way as human beings because it can be really helpful to reflect on past experiences or anticipate new challenges when we're thinking about how to approach an issue. But the problem comes up when we start ruminating on things in the past that we can't change, or worrying about things that haven't happened yet and that might not happen, or that prevent us from participating more fully in our lives right now. So mindfulness is really paying attention on purpose to what is happening right now in the present moment, including the thoughts and feelings that are arising for us without judgment and without getting overly attached to our thoughts. And there is really strong research-based evidence that mindfulness can help people to cope more effectively with anxiety and depression, as well as with physical health concerns such as chronic pain. So a little bit more about mindfulness. I think when most of us think of mindfulness, we think of somebody sitting in an empty room, cross-legged on a cushion, meditating for hours on end. And not everybody thinks that is something they really want to do or thinks it would be helpful. But what I want to say is that while meditation is one practice that is associated with mindfulness, there are many other things that are mindfulness practices. It's really a set of skills for paying attention to your experience with openness, curiosity, kindness, and flexibility. Mindfulness really allows us to acknowledge and accept what is in our lives, to name our thoughts and feelings and accept them as they are, rather than avoiding them, pushing them away, telling ourselves we should feel or think something else. Mindfulness also gives us a little distance from our thoughts and helps us see them as transitory and impermanent rather than something fixed and immovable. You know, when we're able to step back from our thoughts a little bit and see how fleeting they are, we're less likely to get caught up in them, to really kind of believe in them and to act like they're fact instead of just thoughts we're having. And finally, mindfulness helps us to become more flexible in our thinking and expansive, and to really hold and place value on both the negative and positive aspects of our experience, as well as leave some space for new possibilities. So I'm just going to quickly go over a few very brief mindfulness practices. And I wanted to pick brief ones because mindfulness is something that you can do with just a limited amount of time and really almost anywhere. So the first practice is just sitting for 5 minutes and being present with your thoughts. This one you do want to be in a quiet place where you can sit either on the floor or in a chair comfortably and just close or lower your eyes and focus on your breathing for 5 minutes. You can set a timer. You're just going to focus on the physical sensations of the breath going in and out. And what you will notice as you do this is that your mind is going to wander repeatedly. And when this happens, it's not a problem. You just label the thoughts. You can say to yourself, I'm thinking, I'm worrying, I'm judging, and then just bring your mind back to your breath. And in that moment where you're noticing that your mind has wandered, that's when you're actually being mindful. That's when you're doing it right. So don't worry that your mind will wander. If you have just a couple minutes, one thing you can do is just take a moment to notice what is happening around you, to use your 5 senses and to list for yourself very specifically what you can see, hear, smell, feel, and taste. And this is a really powerful exercise, particularly if you're starting to feel yourself become more anxious or even panicky. It just allows you to ground in the present rather than having your mind kind of spin out on worry. And then finally, if you have just a minute or even less, you can practice a few of what we call box breaths or square breathing. And that's just breathing in for 4 counts, holding for 4 counts, breathing out for 4 counts, and holding 4 counts. And you just repeat that several times. And one thing you'll want to do while you're doing this is just pay attention to your belly, because you're going to want to breathe in and out from your abdomen or your belly rather than from your chest. So here are some other mindfulness-related practices to try. And my point in showing these, relaxation techniques, gratitude practices, self-compassion practices, journaling, and mindful movement, is that there are many things that you can do that incorporate mindfulness. And so if one thing doesn't work for you, you can always try something else to find some way to achieve the benefits of practicing mindfulness. And there are some resource slides at the end of this presentation that have links to specific ways that you can practice these techniques. So one final thing that I'd like to mention is this idea of post-traumatic growth. You know, we've talked quickly about post-traumatic stress disorder and other mood disorders that can arise in the context of transplant. But I think it's really important to note that post-traumatic growth is another possible outcome. And post-traumatic growth is really the positive change experienced as a result of the struggle with a major life crisis or a traumatic event. And so it's the positive change that arises from that struggle with something that is really hard or even traumatic and our efforts to deal with it. So post-traumatic growth can show up for us as new opportunities, new goals, new interests, new ways that we want to contribute. Can show up as positive change in relationships, ways that we grow closer to our loved ones, an increased sense of one's own strength and resilience, greater appreciation for life in general, and a deepening of one's spiritual life, however one defines their spirituality. And finally, I'll just leave you with this story of Renata, and I found this on the anthonynolan.org website. Renata is an allogeneic transplant survivor, and I won't read the story, but what I like about it is that it both shares where she struggled, where she had difficulty returning to things that she had enjoyed prior to transplant, as well as where she found hope and possibility after transplant. So it really holds both parts of the transplant experience. So thank you, everyone, for your time today, and it was my pleasure to join you.
Thank you so much. We really appreciate that, Ailey. Some great exercises there. And now our final speaker, Marilyn Wood.
Hello, I'm trying to get to my deck here.
I'll pull you up. 1 second there. There you go, Marilyn.
Hi. So I'm Marilyn Wood. I'm a survivor of acute myeloid leukemia, or AML. And actually, my 1-year anniversary of my stem cell transplant was this past Saturday, October 17th. and the results of my one-year bone marrow biopsy showed no cancer cells. So Dr. Perez, who is my oncologist, has told me I am officially in remission. So the last few days have been very happy days. At least I'm happy with those. So I'm a born and raised Detroiter. I've always lived right here in Southeast Michigan. I like to think of myself as a young, very active 70-year-old who had been an excellent help up until my diagnosis. I've been married to my high school sweetheart for 49 years. We have 2 adult sons and 3 grandchildren. I did not have the opportunity to go to college right after high school, so I attended college part-time whenever I had the time and money. And I received a master's degree in business administration from Central Michigan University in 1999. I've worked in business and education administration until I retired 8 years ago. We love to travel, which of course has been restricted the last 18, 19 months like everyone else. And I have many hobbies, which is a thank goodness as to getting me through this time. On March 3rd of 2019, I went to the ER convinced I was having an appendicitis attack. I had pain in my lower right side, only to find out a few hours later that I had leukemia, which was quite a shock. This was later confirmed to be AML, and I began chemotherapy. This continued through August when I was accepted into the stem cell transplant program at Henry Ford Hospital in Detroit under the care of Dr. Edward Perez, who you met earlier. My transplant was on October 17th of 19. While I was going through all of this, I thought I was doing pretty good. But looking back, there's a lot I don't remember, which goes along with that mindful in thinking about things. My GVHD started to show up in March of 2020, primarily as a very nasty rash. I'm still dealing with this, but I have it under control at the moment, knock on some wood, and we're progressing with treatments, and hopefully we can get this entirely under control. My GVHD did not affect any internal organs, just my skin. I use a lot of steroids, both creams and oral. The worst part was and is the itching. This would keep me up at night. I knitted a lot, which kept my hands busy doing something besides scratching. I looked terrible and slept little, so I could be a very grouchy person. COVID-19 has also affected what I do or don't do, but it's affected us all. I've become very aware of my surroundings and the people around me. I'm at home a lot, and visitors are limited. They're used to me asking about their health before I say come over. But this has now been a long time. I've virtually been doing this for 18 months, and I'm getting very antsy to start getting out and know that I can't, and winter's approaching. We have a friend, acquaintance in Chicago who owned the very best restaurant we've ever been to. Ina Pinckney is a survivor of childhood polio, which was the pandemic of the 1950s, and it has reoccurred as an adult. She had to give up her restaurant, but still makes personal appearances in Chicago and local TV. She has a quarterly newsletter, and the following was in her spring 2019 edition. It was immediately posted on my board and came with me to hospital stays. I read them every day. They're very strong. Don't fear time alone. You're going to be alone a lot. You have to learn to like yourself for whatever you're worth. Don't dwell on the past. That's never going to be the same. Don't feel the world owes you something. It doesn't. Don't expect immediate results. This one's hard. They change your medication and you think, tomorrow I'm going to be fine. It doesn't really work that way. This is a journey, and it's a different journey for different people. Don't waste time feeling sorry for yourself. It's not going to do any good. You have to be proactive, okay, and do things to make yourself better. Don't waste energy on things you can't control, because frankly, you just can't control them. Find time and energy to work on things that can help you. Don't let others influence your emotions. These are the people that come and say to you, oh, I'm so sorry you're sick. You know, you don't need that. You need people who are going to make you feel better. Don't resent other people's success. This is part of this journey. Some people are going to get there faster. Their route is going to be easier. And you have to be happy for them, where yours may be a different way. Don't shy away from responsibilities. Managing this disease is part of your responsibility. Keep a journal, ask questions, do what your doctor says. This is your responsibility. Don't give up after the first failure. So when you have GVHD and the first medication or cream they give you doesn't do a thing for you, you go back to your doctor and say, okay, I'm ready for plan B. What else can I do? So you cannot give up. And don't fear taking some calculated risk. Your doctor may suggest an experimental procedure or a trial or a new med. Try it. It may help you a great deal. These next ones were ones I added because I don't like negatives, and Ina had don'ts and everything. So I had do's. Do keep a diary or a notebook. If you can't do it, have a family member do it. You can refer back to, I refer back to things that happened in March or in April. You can also put some of your feelings in there. You can make notations about different personnel you ran into and how you feel about that person, what kind of care you got from them. So a diary or notebook, I think, is really essential. Do listen to your doctors and caregivers. Now, I'm not saying you got to do everything that they're telling you, but listen to them. They have a wealth of knowledge. And going along with that is do ask questions. Even if the question is, would you repeat that? Okay? Look up things online. Come back to your doctor. Ask questions about it. You have to learn to educate yourself. Do trust yourself. You know what you're feeling. You know that the ache is in your shoulder or it's in your belly. So do trust yourself to tell your doctors and know that this is not normal. I need some help in some way. Do cry. You're going to cry. And it really can help how you feel to get that emotion out. So don't be afraid to cry. My next one's a lot of fun. Do eat ice cream. Okay, your weight will go down while you're going through this. And the fun part is eat some ice cream, but always share it with someone else. You don't have to eat a lot of it, but eat some ice cream or whatever else makes you feel good. Do smile. Now this is a little hard while you have these hospital masks on, but actually if someone can see you smile, they usually smile back. And when you smile, you feel better. And when someone else sees the smile, they feel better. So smiling is very important. Do accept help from others. This goes along with that self-pride. You've got to learn to swallow your pride and accept help. When someone says, can I cook you a dinner and bring it to your home? Say yes. For one, they'll feel better, but it really does help. So if anybody wants to help you out, accept that. It's a great thing. Okay. Thank all of those who are helping you and caring for you. And this, I always said, includes the facility staff at the hospitals who very seldom are thanked for washing your floor every day. But do thank all of these people. It may be their job. However, they care for you, and they do like to be thanked. My last one is very personal, and it's do pray. I know this works. I had people from California to Pennsylvania, Michigan to Florida praying for me. Some I didn't even know. I got cards from perfect strangers, and it was wonderful and uplifting. God does work in mysterious ways. Yes, he gave me AML, and the last 18 months have not been great, but now he's given me so much more, and I am very thankful. Whichever way you need to do this to show your thanks. I'm convinced that God got me to the hospital that very first night when my thoughts were on appendicitis, and I found out I had a platelet count of 2 that night. The next day the pain was gone and never ever came back. Whatever that was got me there. So prayers can help, do help, and remember to pray for other people too. So thank you very much.
Thank you, Marilyn. You sound like an honorary social worker as well as you're just a very cool lady. I love hearing your tips, and I appreciate you bringing them today. Okay, it is that time of our program where you can ask some questions. We will certainly get to as many as we can, but we probably won't be able to get to them all. However, if you come down at the bottom of your screen, for those who haven't noticed it yet, there is a question area that you can type in your question. So feel free to do so, but we'll start addressing some of these. The first one I would imagine is probably good for Dr. Perez. I think we know the answer, but I'd love to hear you say it. Intense back itching, is it possible it could be skin GVHD?
Yes, so any pruritus, any itching that develops in any areas of the body, it can initially involve the drape of the neck, the back. It is important that you do a whole body type screen daily just to make sure there's no development of any areas of redness, as well as the itching definitely can be a symptom of graft versus host disease.
Another medical question, can you speak to autologous tears for ocular GVHD? How long is one usually treated with them?
So, yeah, that's a very good question. And ocular GVHD really requires a very close follow-up with the ophthalmologist in regards to utilizing 3 different modalities that I incorporate have been the dry eye wipes and the lid wipes, as well as the artificial tears. Those you can do it, every hour to every 3 times a day, and the duration of those in patients who have dry eyes can be lifelong after transplant if needed.
Okay. What about, does diabetes impact chronic graft versus host disease?
So that's a good question in regards to, one, the type of diabetes, if it's type 1 versus type 2. And we know that any inflammatory cascade can lead to that HLA disparity, or those inflammatory cells kind of revving up. And so diabetes itself is an autoimmune type of reaction that, again, as against the islet cells in type 1 and type 2, it's more due to insulin resistance. So the manifestations of chronic GVHD and the requirement of steroids can really alter the amount of medications you need to treat your diabetes, and it may not exacerbate the chronic GVHD or lead to it, but again, that cascade, once you have to incorporate corticosteroids, can be pretty significant with regards to the medications and the sugars that you have to control.
We have quite a few medical here. I'll throw this one to you too, Doctor. If I tested positive for COVID for several weeks, but subsequently tested negative, what are the chances that I have any immunity?
Right. So that's a great question. That's a question we get all the time in regards to the immunity after one has become COVID positive. So that duration of immunity in the normal patient population is being tracked, and data is coming out in regards to how long the immunity lasts. It seems to be based currently on the severity of disease, and so those who only get mild symptomatology, their immunity is not long-lived. It seems relatively short. So I think I would, even though you've been had COVID, and it sounds like that the duration of your symptoms were not prolonged, or they were manageable without hopefully requiring hospitalization, the immunity, again, if it's mild symptomatology, does not seem to be long-lived. And with concomitant immune suppression or additional therapies, again, the immune response is not as significant.
Thank you. There's another question we have here that's kind of specific to the patient, but they have some concerns that they have been on chemotherapy and had a relatively good response, but their oncologist is talking about a bone marrow transplant regardless of that. Is that something that you hear of in your practice?
So depending on the type of a disease, there are many situations where you can have a certain type of either lymphoma or type of disease that requires that you be considered for what they call a consolidative transplant or high-dose chemotherapy to keep you in remission, even though, and that's a common question, you're able to complete or maintain a complete remission after your initial treatment or induction therapy. So that is something, depending on the diagnosis, that we do is once we've treated patients with therapy, we consolidate them with high-dose chemotherapy and transplant.
Thank you. Also, we have one writer here that says, how common is secondary cancer after a stem cell transplant?
I'm sorry, you broke up a little bit there. Can you repeat that?
Oh, I apologize. One writer asks, how common is a secondary cancer after a stem cell transplant?
Right, yeah, so that's a very good question. So the incidence of skin cancer in patients who have undergone either autologous and allogeneic transplant can be very high, so we recommend that they see their dermatologist on a routine basis, at least yearly, to do an overall body check because it can be 1,000 times greater. Even if they're off immune suppression, we do recommend sunscreen, hats, sunglasses, and again, avoid exposure to the skin from the sun. In regards to secondary malignancies such as MDS and transformation into leukemias after a transplant, really depends on the conditioning you've received. The incidence can be in the range of 5 to 10% lifelong.
Thank you. And another one here, have you heard of sclero cream for GVHD scleroderma?
So there's many different emollients and combinations of creams with petroleum-based, non-petroleum-based, as well as creams that are utilized with a steroid base. So most of them have their different names or combinations to utilize them. There's a combination. So again, that's not one that's a trade name I'm as familiar with. Maybe one of the survivorships has some more information about that, but that's not one that I utilize. But again, they do go by different trade names.
All righty. And then one last question. Why do some people get a small spleen after transplant?
So patients who have undergone stem cell transplant, depending on the conditioning regimen, with either total lymphoid irradiation or total body irradiation, can cause involution of the spleen. Also, the chemotherapy they receive can make them functionally asplenic. So there's many different parameters that can lead to either asplenia or functional asplenia or decreased spleen size.
Well, that is our program for today. I want to thank everyone for joining us. We hope you gained at least one new tip to help you, and we had some great information. I also want to thank our speakers. They were certainly a dream team, and I thank you all for taking the time to be here with us today. And of course, our sponsors and our partners. And just a reminder, there will be a survey if you stay on that you can fill out. Let us know how we can continue to provide programs to you, improve them, or any topics you're interested in. And but that concludes today. Thank you, everyone, for being with us today.